to the webinar. This collaboration between NAEMT and AIMHI. Follow the money, how EMS is financed, the first in a series of webinars that's going to tell you how to make, if you believe that money in the middle, $1 million in EMS. I'm Chip Decker. I'm the CEO of Richmond Ambulance Authority, and I'm joined by Matt Zavadsky, my distinguished co-host. Special thanks to our sponsor, Zoll, for sponsoring this collaboration. Hopefully they will continue to do so and assist with getting the word out and getting the message out for our industry.
And today, if you would like to ask a question during the webinar, click on your questions box in your GoToWebinar toolbox that should be on your screen to your right or your left. Also minimize that by pressing the back arrow, or you can to full life by pressing the back arrow. And then you click on questions, and then you type the questions into the text box. They will come into us, and then we will have a Q&A during different points of the webinar.
All right, thank you, Melissa. And again, thanks for everybody for logging in and watching the webinar this morning, or afternoon, depending on the time zone that you're in. And Melissa, I've lost control of the screen, so hopefully we'll be able to get that back. But we wanted to tell you guys about the goals of why we're doing this webinar. And it is going to be an entire webinar series, and we'll show you those series topics here in just a moment. But first, our hope is that all levels of EMS professionals will understand the economics of how EMS works. It is very common for managers, supervisors, to understand the economics of EMS, but oftentimes the folks who make the most difference, the folks in the field, don't really understand the economics of EMS in general. Second, we need to understand that our role in the healthcare system is evolving. It's changing. Things like ET3, mobile integrated healthcare, community paramedicine are really evolving EMS into the healthcare system as healthcare practitioners, healthcare providers, and we need to start thinking like that. Healthcare is a very unique economic model, and the more that we can explain to everyone that's involved in EMS delivery, the better we're going to be as a profession to be able to drive change that makes the field more rewarding for all of our practitioners, the field level, the leadership, throughout the entire organization. And we're going to talk a little bit about AIMHI and a little bit about NAEMT, but you'll see some of the topics that are coming up in this particular webinar series, and at the end we'll tell you when those next ones are going to occur so that you'll have the opportunity to do that. Next, I want to talk a little bit about NAEMT. For those of you that aren't aware, NAEMT is a very large organization. The interesting thing about our membership is that it's about a third, a third, a third. So a third are in the public sector, a third are in the private sector, a third are other, hospital-based, volunteer. So your membership really is very diverse. And for that reason, the board and the leadership at NAEMT often take a little bit longer to make some positions, but we really want to get a sense of the membership that we represent and the folks that have entrusted us to be their representatives nationally, locally. Chip, tell us a little bit about AIMHI.
So the Academy of International Mobile Healthcare Integration, AIMHI, represents high-performance emergency medical and mobile healthcare providers in the U.S., Canada, and abroad. Member organizations are high-performance systems that employ business practices for both the public and private sectors. By combining industry innovation with close government oversight, AIMHI affiliates are able to offer unsurpassed service excellence and cost efficiency. And there you see some of our membership. Or not.
Oh, there we go. Just a little bit of a lag.
There we go.
Excellent. All right. Well, thanks, Chip. That was a good overview, and certainly we encourage folks to join both of those organizations as they apply. Okay, so let's first talk about the source of funds, Chip. So there are a number of ways that EMS organizations get funded. There's fee-for-service and subscriptions are the first two things that we'll talk about. Fee-for-service could come from the things that you see on the screen, transport fees, treat and refer fees. And Chip, what's the case where someone might charge a treat and refer fee as opposed to a transport fee? What are some examples of that?
Well, treat and refer. Let's say we're going and attending to a patient, and they can be better served somewhere else. And can you charge that patient just the fee for response?
Exactly right, and that could be a smaller bill, perhaps. I know in our system at MedStar, that fee tends to be a little bit less than our transport fee. In fact, a lot less, about a third of our actual transport fee. A lot of organizations do standby and event medical, other specialized services. Let's focus a little bit on subscriptions. Chip, does Richmond Ambulance Authority offer a subscription program to their residents?
We do have a subscription program. We call it Lifesaver, and for a fee, an annual fee, you can subscribe. And what that gets you is if we come out and take you to the hospital, if it's medically necessary, if your insurance pays just the first dollar, then the program pays the copay. However, if you don't have any insurance or your insurance denies you as not being medically necessary, then you get a 20% discount. And there's a lot of rules that govern these subscription programs. They got to be actuarially sound, and but it's a good way to keep the population that you're serving from having to get that extra bill at the end.
Yeah, and it would certainly help with some of the balance billing issues that we're hearing about in some of the media. So that is important. And a lot of systems do offer subscription programs. So if that's one way that you might think your organization can help with some of the fund generation, certainly reach out to Chip, myself, others. We can kind of walk you through how that looks. Some states, it's a little bit harder to do than in others. Some states don't allow it at all because they consider it insurance. But a lot of states will generally allow an ambulance subscription program because it does make sense for the patients and makes sense for the organization. Another source of revenue is tax subsidy. So this could come from either direct funding from ad valorem or property taxes, sales taxes. There may be special use or assessment. So in some communities, they will have a penny sales tax or a half-cent gas tax or some other type of revenue generation publicly based on those purchases or property taxes that could be dedicated towards the EMS organization. And in some cases, that could be a lion's share of the cost, or I'm sorry, of the funding that comes to the EMS agency. And Chip, I believe, does Richmond get a tax subsidy?
25% of my income, if you will, comes from our tax subsidy from the general fund from the city of Richmond. And so the rest of it we get from billing collections. But yeah, that 25% equates to about $5 million for us.
Yep, and we're going to talk more about that in just a minute and how that is impacted or could impact patient fees that are charged by the agency. Then there's some unique other funding sources. GEMT has been around for a while. This is a government program where public agencies are allowed to get cost recovery for the service that they provide if the Medicaid program in that state underpays. So I know in Texas here at MedStar, we file a cost report with the state Medicaid office every year, and there's usually a difference between what Medicaid reimbursed us for the services that we provided to Medicaid patients, and they give us a portion of that money back at the end of the year. On our $49 million budget for the last several years, that's equated to about a $3 million reimbursement. In some cases, that offsets the underpayments that Medicaid may make because they tend to be a very low payer. They could also, agencies get grants. They may get funding from parent organizations. This is very common in hospital-based systems where the hospital-based ambulance provider might be not making or not breaking even, but the hospital still funds it out of some of their operating expense because they recognize some other community benefit from having that service available. And then a lot of volunteer agencies do rely on donations, bake sales, and we hear about that all the time. And one of the things that both AIMHI and NAEMT do on a regular basis is to try and figure out how can we make some public funding or donations or things like the Siren Act that many of you have heard about more available for folks. So Chip, let's take a moment and look at what, when we put some of these things together, what this looks like truly from a budgetary perspective and how impacts of things like patient receipts and monies received from service generated and tax subsidy really have a impact on some of this. And we're going to look at, this is a sample organization, above average EMS ambulance, and this is going to be their budget. So we'll just assume for a moment that above average EMS does 3,000 patient transports, $2 million expense. And when you look at their revenue mix, this sort of where the rubber meets the road, especially for the field providers who may not understand how some of this all works together. So let's say that they collect $1 million for patient transport, $15,000 in standby revenue, they get $20,000 in grants, they do get some GEMT of $17,500, they have a subscription program, so they generate some subscription revenue and donations. All those things that we talked about are part of the revenue. However, much like in Chip's operation in Richmond, all of those things combined still will not fund enough of the organization for the organization to provide the service level that the community wants from above average EMS. So in this particular case, there's a shortfall between their revenue and their expenses of $917,000. The tax subsidy then comes into play. So or the local community, the county, the city, the township, whomever says, yes, we're going to cover that cost for you so you don't operate in the red. And the tax subsidy for that is going to be, we're going to cover that $17,500. Now, in this particular case, when you do the math and you look at what their fee for service is, and their dollars collected per transport is $333.33. So we'll just use that. That's not what they bill. That's what they collect. And Chip, what's the difference between billed revenue and collected revenue? We were having that conversation right before the webinar started. Talk to us about how that works in Richmond.
Yeah, we were having that conversation. It's a sad conversation because, you know, I have a retail rate. And so that's what it says on my bill. Where else but healthcare can you have a retail rate and people pay you whatever they want? So just because I charge, pick it $600, you know, if my Medicaid reimbursement is $150, which it is, then that's what I get for the transport. So it's a huge difference.
Yeah, so that's a big consideration, and that really impacts the dollars that are collected. And a lot of organizations don't understand part of that dynamic. So if you were to raise your rate, so in Chip's example, if he gets paid $150 from Medicaid, and let's say he gets paid $250 from Medicare, those rates are fixed. Those payment rates are fixed. So it doesn't matter what you charge. You could charge $1,000, and you're still only going to collect $150 from Medicaid, $250 from Medicare, and then you'll see how some of that plays out in the rest of the payer mix, because we're going to have a payer mix conversation. Now let's see if we can get to the next slide here. I apologize. There we go.
There you go.
So here's above average EMS once again. And let's say that they raised their fee, and because they raised their fee, they collected more in their fee for service revenue than the $1 million. So if they had a higher fee, as you can see, they have a lower shortfall because they're collecting more in cash per transport. So their subsidy can be less. So the public dollars that are needed to fund that, because they are charging more and therefore collecting more, make the program a little bit more self-sustaining, but in this particular case, still not enough to cover their costs, but they are charging a much higher fee. Chip, when you guys determine your rate that you're going to bill, what are some of the things that your board and you take into consideration in determining what that fee is going to be, what that charge is going to be?
Well, I report to a board of directors, and so sometimes things can get fairly political. So one of the things we're going to look at is what are the surrounding localities, what are they charging? And we'll always be a little bit higher, but yeah, what are they charging? And then we're going to look at expenses. We're going to try and figure out, all right, what is it really going to cost? What is the market for, paying for paramedics and EMTs? And so then we're going to adjust our rates. And we did that. We did that a little over a year ago and increased the rates $100 across the board. Retail rates up $100. So, you might think, oh, I'd be getting $100 more per call. No, the reality of it is because of all the fixed payers out there, I got $14 per call average increase for my $100 retail rate increase. It almost wasn't worth the political, to get the thing. So we have 14%.
So Chip, in your model, your community has, and your board has made the determination that they're going to kick in some public dollars to help deliver that highly reliable paramedic on every ambulance, the response times that they want. So you know that it's going to cost you $6 million, whatever the number is, and that without charging $2,400, you can't collect enough money to meet your budget. So the community says, okay, we're going to chip in some dollars so that the rates are reasonable and we can get the high quality service that we want. Is that a fair assessment?
It is. We did an exercise just to see what would our rate have to be if we did not want to receive a subsidy. Could we ever be self-sufficient? We stopped counting at about $2,600 base rate because it just wasn't going to happen. There's no way. So
yeah, that's when your city council members start getting phone calls and emails from their constituents saying, "Holy crap!"
Right. Yeah. $100 is one thing, and that was tough enough. I don't know, $2,000. Yeah.
Yeah. So for contrast and comparison, when you look for the webinar participants on the screen, when you increase your cash collected per transport from $333 to $500, that may be, as you heard Chip explain, a $1,000 bill as opposed to a $500 bill. Here at MedStar, our average patient charge is just north of $1,500. It's $1,505 is our average patient charge, and for that we collect about $425, $427, and because of the high fee and the revenue collected per transport, we do not currently need to get a tax subsidy. So we, for the last 10 years, have been able to collect enough dollars in patient service fees to not have to get public funding. However, it does generate, as you can probably imagine, some phone calls. Why do you charge so much? Why is the fee so high? I was just in Richmond and they only charged me $600. I crashed my car in Fort Worth and it cost me $1,500. And we explained that the goal of the cities that are part of the authority is that the system, to the extent possible, be not tax supported, and that the people who use the system are the ones that should pay for the service. So it's just a different philosophy. So let's go back to above average EMS. Let's say that they did have that $1,500 or higher patient transport fee. We're doing a little project in California, and the average patient bill in San Diego is $2,600. But of course, the cost of living in California is a little bit different. So you can see how all that works. But if above average EMS were charging that $2,000 and they were collecting 30%, and they got to a $666 reimbursement, they could actually come off of their tax subsidy. But again, they would have to generate enough revenue in that fee for service to be able to do that. So Chip, let's talk a little bit about payer mix. And first, could you maybe for the participants on the webinar explain what do we mean by payer mix?
So payer mix, when you transport somebody, because we only get paid if we, here in Richmond, if we transport somebody. And so what do they have? What kind of insurance do they have? Do they have Medicare, Medicaid, private insurance, or as is the case for like nearly 20% here, do they not have anything? And so we take that into account with, whether Medicare, our largest payer, is going up or down. Here in Richmond, Medicare, Medicaid accounts for almost 60% of what I bill, or the people I transport. And insurance is about 9%.
Yep.
So private insurance.
Yeah, and what you folks on the webinar see on the screen, this is the actuals for Metropolitan Area EMS Authority. This is the MedStar system. And for 2018, you can see what our payer mix was. And that percentage of what we bill and the patients that we transport is what you'll hear referred to as the payer mix. And Chip did a great job explaining it. We throw facility in there. I'm sure most systems do that because they have hospitals or other facilities that pay for the service. But notice that we would have billed, and we did bill in 2018, $165 million in ambulance services, fee for service, and we'll talk what that turns out to in cash here in just a quick moment. So Chip, talk to us a little bit about, let me go back up here, commercial insurance, and how is the rate that we collect impacted when we bill a commercial insurance company like the ones that you see up on the screen?
So commercial insurance, for me, they can pay the best, or they can be less than helpful in getting us some revenue. Commercial insurance has changed over the years. Now you got the high deductibles, and so folks, are now have $5,000, first $5,000 or more, comes out of their pocket. So the usual and customary rate is what you can hope to get in your area, and it varies. It varies. If you're from a state, say Pennsylvania or Texas or California, that have had paid EMS or fee for service EMS longer, then yeah, your rates are probably going to be higher than someplace in Virginia that came to the party kind of late. So depending on the policy that the patient has, it depends on how much you're going to be paid. Used to be, a Blue Cross Blue Shield policy was 80% and the patient was on the hook for 20. Now it could be anything. It could be $100 that policy pays, and so it's just all over the place. And then when you add in deductibles and co-pays, sometimes it's hard to get the money, and sometimes they don't even send the money to us. So,
what do you mean not send the money to you? I mean, you billed them. Who would they send the money to?
Well, sometimes they send it to the patient. The patient's their policy holder. We had a little discussion with some of our providers here in Virginia a few years back, and so for the most part they send it to us because we're the ones that need it. But if they send it to the policy holder, now we got to go after the policy holder, and that's when we start to look unnecessarily like the bad guys.
Right, because we're going to go after mom or dad because hey, they got that $1,000 payment from the insurance company and they went and got a new television for the kids. And no, that money was supposed to go to the ambulance authority to pay for ambulance bills. So that's sometimes very difficult. And then medical necessity is a big issue. And some of you may have read recently the insurers, the commercial insurers specifically, have been really clamping down on this medical necessity issue. And just because somebody goes to the emergency room, just because they call 911, doesn't mean that the insurance company is going to determine that to be medically necessary, and they're going to deny the claim. And Chip, we're going to do more of this in a future webinar, but how do field EMTs and paramedics impact the ability to demonstrate medical necessity?
Oh my goodness, that comes back to documentation, because if you can't explain why you're there, what you did for the patient, the benefit that your training provided for that patient, and that the patient needed to go to the hospital in the first place, then chances are our bill's going to get denied by the insurance carrier. So yeah, the documentation is going to be critical.
Exactly. Now, I just want to focus on one thing, Chip, that you mentioned a little bit about usual and customary. So let's say in the Richmond area, let's say that most of the communities don't rely on tech support. They don't get any subsidy. And because of that, like let's say above average EMS, they have to charge $1,600, $2,000 for an ambulance bill, but the Richmond Ambulance Authority is charging $600. What impact does that have potentially on the regional, usual, and customary rates?
Yeah, that has a huge impact because when payers are looking at the region, so if you have somebody like us who's trying to survive, not making a profit, and then you have another locality who is, let's say, charging just a little bit, because they're, whether it's the soft billing or whether it's the, the low rate because they're just dabbling in, a lot of localities here are just starting to charge, or that they've only been doing it for a few years. And that's really tough on us because, an average of, my 600 and somebody else's 300 is going to hurt.
Right. So the impact of that subsidy and people charging a lower rate could make it difficult to collect the dollars that you bill from the commercial insurers. So that becomes a real interesting challenge. So
absolutely.
And Chip talked about who gets the money, very important. We talked about medical necessity, so making sure that you're doing everything that you can, because if you like getting paid for the services that you provide, if you like that hourly wage and being able to do those kind of things, you have to help the organization collect those dollars for the services that you are providing. We're gonna spend a whole webinar on talking about that. So let's put some real numbers to this. So again, we're going to try and be as very specific as possible. And MedStar is a public agency, so we share a lot of this information publicly, and it's very important that we do this. But here's an example of the commercial insurance. So in 2018, we billed $21 million in bills to commercial insurers, Aetna, Cigna, United, the Blues, etc. That represented, in the payer mix terminology, 12.9% of what we billed. Now, if you look to the right, you will see that cash collected, in terms of how much cash we collected overall for 2018, 38% of the cash that we collected came from commercial insurance, because the commercial insurers pay, on average, for us, 76.6% of what we charge them. So that's why you heard Chip say that insurance can be some of our best payers. We're going to talk more about the cost shift here in just a moment, but you'll see these are real dollars, what this means to an organization when they're billing commercial insurers. Chip, why don't you talk to us and educate our webinar participants, and probably even me, a little bit about Medicare and the difference between Medicare fee-for-service, Medicare Advantage. How does that work?
Well, there's a bunch of different types of Medicare. The fee-for-service, that's kind of what you think of as your standard Medicare, your older population, and I mean, it's the majority of the folks that we take to the hospital, and they have their Medicare allowables, and that's kind of what we're going to get paid. Hopefully, they have some co-insurance that we can also bill if we're lucky enough to capture that information, on the call sheet. And then you have these intermediaries, and so these folks are doing it on behalf of Medicare, and so these people, they kind of are doing the same thing, but yeah, they're probably on the hook for the total cost of that person's healthcare, and they may not, they may not want to pay you when you think you should be paid.
Yeah. But, so the Medicare Advantage or the managed Medicare programs generally follow, Chip, the same policies as Medicare does, and arguably, unfortunately, the same rates. So because they're a Medicare Advantage plan, they pay the same way Medicare would on the fee-for-service side, and they pay essentially the same rate. Is that pretty true?
Yeah, it is. And so even though they are literally an insurance plan.
Right. So that's why you'll see you're in the field provider, when you see that patient's insurance card, it'll say Aetna Managed Medicare or whomever. So this is really that Managed Medicare program. And you'll see some of the challenges with that. They bill usually, or they pay typically below the cost of service. And some of you may have heard about an initiative being undertaken by CMS and the RAND Corporation to analyze the actual cost of ambulance service so that they can determine whether or not the fees that are allowed by Medicare are covering that cost. It's a very important initiative for the ambulance industry because we generally know that it costs more typically to provide an ambulance transport to someone to the hospital than we're reimbursed by the Medicare program. That's even before deductibles and coinsurance that, again, Medicare patients are required to pay as part of that. So let's go back to the MedStar analysis. So here was what we billed to Medicare in 2018. You'll see that it's about 37.6% of the total dollars that we billed. We collected 17 million. So it represents about 40% of the cash we collected because it was so high of the patient volume. So the payer mix for Medicare is high. But you'll notice that they only paid 27.5% of what we charge. And that's to what Chip talked about earlier, where it's a fixed amount. You can charge whatever you want. They're only going to pay $400. So that's why even when you raise your bill $100, it only means $14 net at the end of the day in cash in the door to help meet expenses in your EMS organization. Chip, talk to us about Medicaid, fee-for-service, and Medicaid managed care.
Medicaid. Okay. Well, and so that's our biggest challenge. You know, it's a combination of, you know, state and federal, and you got to convince people, you know, sometimes Medicaid rates can stay the same for years and years. Rarely do they even approach the cost of providing the service. So managed Medicaid is a company that Medicaid is going to contract with, and they're going to get all the dollars, and then they're going to do all the scheduling, all the paying, trying to figure out, was it medically necessary? Did you need pre-approval? And there's a ton of hoops for very little return. So particularly on these calls, if any other call, documentation is key, because if you end up having your billing department spending $30 to collect 150, trying to chase down this money, it suddenly becomes not worth it.
Yeah, and Chip, one of the things that we've seen in Texas, I don't know if it's true in Virginia, but in Texas, Medicaid managed care enrollees can change their managed care program every month. So imagine you're the EMT, you're the paramedic, you're the billing person who's trying to collect these dollars, and it's August 20th, and we take Melissa Trumbull to the hospital, and she's on Medicaid, and she's in Aetna's managed Medicaid in the state of Maryland. And by the time we bill this, September 10th, she's no longer with Aetna, now she's with Amerigroup. It just becomes this major hassle to try and collect those dollars. Chip, do you see that in Virginia as well?
We see a little bit of that. I mean, the challenge is that it's almost like they're paid not to pay you. And, you know, they want to save the money, they delay the payment. So yes, getting it right the first time, getting the bill out the door is key with these folks.
Yeah, and again, fixed amount, so it's a huge challenge. It's better than nothing. We're going to talk about the nothing here in just a moment. And a lot of the Medicaid patients are high utilizers, because in many cases they are on Medicaid because they have significant medical issues or they have significant economic challenges. So they tend to use the healthcare system a lot, which is why a lot of the Medicaid plans look towards things like mobile integrated healthcare, community paramedicine, to help those patients not use the ER as much. So here's again back to the analysis for MedStar. 2018 Medicaid was about 26.8 million, 16% of what we billed. It was 11% of what we collected, and you can see they pay on average a whopping 18%, 18.7% of what we bill. Now we're very blessed in Texas. The rate isn't too bad. You know, it's about $250, $280. There are states, Alabama, Georgia, some places where that Medicaid rate is $75. And Chip, you had an experience with that recently in Richmond. What was your experience in working with the state on your Medicaid rate?
I did. It was $75 here in Virginia. It had been for 20 years, and about 6-7 years ago, I decided, okay, I can't do it for this. And I literally had to, for 2 years, had to go to the Virginia General Assembly, in order to get them to vote up a Medicaid increase. And so they increased it. They doubled my Medicaid rate, so now it's about $150. And but holy cow, it's just incredibly it's incredibly political when you're talking about Medicaid rates.
Yeah, because it's big dollars for the state. Hey, we want to mention a quick thing about in-network arrangements. So many of the participants on the webinar may have read, seen, heard this whole concept of balanced billing, being in-network, out-of-network. And we're just going to be real frank. For organizations like Richmond Ambulance Authority, MedStar, fire departments, other organizations that primarily are 911 providers, they oftentimes are the only provider in that market. Going into network does not make any economic sense. So as you can see on the screen, the basic model for in-network, and this applies to physicians and hospitals, everybody else, includes ambulance, that you're going to agree to accept a lower payment rate. So you say to Humana, hey, instead of the $400, we'll accept $350 as full payment for that service in return for higher volume. So you see that a lot in physician practices. They'll get more patients through the office. They gain some efficiencies, and they can at least maintain their economic balance and maybe even do better because they're getting a decent rate, but they're seeing a higher volume. For organizations like CHIPS, like ours, our 911 volume generally is not going to change because we go in network. So the same 1,000 or 100,000 Blue Cross Blue Shield members that are calling 911 are going to be calling 911 tomorrow, whether or not we're in network. So the basic concept of the in-network does not work for us and for many communities. So that's why AIMHI, NAEMT have been working with Congress and the National Governors Association and the America's Health Insurance Plans to have them understand that model. Plus, being a safety net provider, we have to respond. If somebody calls 911 in Richmond, CHIP's billing office isn't going to run their credit first to see if they're already owing Richmond Ambulance Authority money and say, hey, we're not coming unless you give us a credit card to bill because you're not paying. We have to respond. The patient doesn't have to pay. So as that safety net provider, it again makes network arrangements a little bit more problematic. So if you want more about that, we're going to talk more about that in future webinars. But that's just sort of the high overview. Chip, any comments about the network arrangements?
No, we don't do it at all. The last thing I want is, more volume, and I'm certainly not going to accept less money to get. No, not going to happen.
So Chip, let's talk about the uninsured or the underinsured. Why is this so hard to collect from patients? Why is the dollar hard to collect?
Well, sometimes they're hard to find. I mean, we have a large homeless population here, and so it's hard to, send a bill to the, under the I-64 bridge. And the reason, they're self-pay is because they don't have anything else. If they had means, they would have insurance. If they had means and a job, then they, could potentially have insurance. So, while, the private pay for me is 15% of what I bill and 8% of what I collect.
Yeah, let's put some numbers around that. So you just heard Chip's numbers. Here's MedStar. So again, Fort Worth, Texas, our primary service area. In 2018, we billed $52 million. It's one of our highest. So it's 31.7% billed to patient because they didn't have insurance, they were homeless, or whatever the case might be, as Chip talked about. But we collected $1.6 million. So that means that they represent about 3.9% of the cash that we collect, but on average, we only collect 3% of the dollars that we bill to the patient. We did a recent analysis as part of our ET3 evaluation, and the average payment that we receive for a patient that we privately bill for an ambulance trip is $56. And that's because so many don't pay at all or just pay a small percent and then just quit paying. So it becomes a big deal for us. So the more that we can in any organization, so those EMTs and paramedics in the field, getting insurance information, trying to figure out, is there a payer other than the patient? Because chances are, if it's the patient responsible for paying this bill, it's just not going to be collectible. It's very, very difficult. So Chip, in Richmond, you have some pretty high-powered, very well-respected healthcare systems. And some of those healthcare systems have contracts with you to provide service. Talk to us about how facility contracts work.
So facility contract, different totally from in-network provider. Facility contracts, I've got them with hospitals, hospital groups, hospital chains. And when they want to keep their patients in network, they call us, we move them around. Now, it is also that they can be the payer of last resort. Let's say they need to get somebody out of the emergency room and they call us. Well, we do ambulances, and there is a chance that that patient may not truly need an ambulance to get out of there and go back to wherever the skilled nursing facility they came from. And so in that case, we'll take the patient. We know it's not going to get paid for. We bill it for the denial and then charge the facility back. And so, yeah, payer of last resort, if you're going to do it, it needs to be in there. And then we come to an agreed upon, rate that is beneficial based on how much time they're going to give us to show up, and adding in the cost of readiness a little bit to that.
Yep, the great example. I'll give you this funny story, Chip. I was with a good friend of mine in Michigan over the weekend, and he was telling me a story about one of his crews went to the hospital emergency room to take a patient home from the ER, and there was questionable medical necessity, but they're owned by the hospital system, so they said, okay, they went, and when the crew looked at the address that they were transporting the patient to, the crew said, seems kind of like a weird address, I'm not really sure, but okay. So they load up the patient, and when they arrived at the hospital emergency room, by the way, the patient was walking in the hallway, but they, put the patient on the stretcher, put the patient in the ambulance, and when they get to the destination, there was no house there. There was no apartment. It was literally a field. And the crew looked at the patient and said, so this is what's listed as your home address, and you're going home. And he said, oh, this address doesn't exist. I'm homeless. I just gave them this address just because it came to mind when I registered, when I arrived at the emergency room earlier this morning. And by the way, the reason that they called the ambulance was because when Uber took me to this location 3 hours ago, they wouldn't leave me here. And they brought me back to the emergency room, so the ER called you guys because they knew that you would just leave me here. Like, seriously?
Yeah. That happens more often than you think. You get a street corner because if they are homeless, but holy cow, yes. What do you do with the folks? Yep.
But thank goodness the EMS provider there had a payroll of last resort contract with that hospital, so that hospital is going to get that bill for the transport home, and it probably would have been better and the hospital apparently tried to pay Uber to take the patient home, but they wouldn't just leave them on the street.
Uber wouldn't do it. That's classic. Yeah.
So here's an example of the facility for MedStar. Now, again, it's a very small percentage of what we bill. It represents about 1.5% of the services that we provide, and about 5% of the overall cash that we collect. But for a little bit of a statistical anomaly, we actually collected more in facility fees due to a quick crossover issue at the end of last fiscal year. But they pay almost 100% because it's a negotiated rate. They know it up front. There's no deductible co-insurance, and it just works out pretty well. And quite frankly, we bill them what the rate was that we agreed that they were going to pay for that as a payer of last resort. So, Chip, as we begin to wind down this first part of this webinar, which is sources of revenue, sources of funding, let's show this entire payer mix for the MedStar organization. So as we've talked about through the webinar, insurance, 12.9% of what we billed in 2018. It represented about 38% of what we collected. And again, you see that 76.6% collection rate as compared to the bill patient. And we talked about those statistics already. So that is very important that people in the field and all across the spectrum, even in dispatch, really help determine medical necessity. Can we find a third-party payer? Is this going to be a payer of last resort for the facility? And then the total that you see there, so in 2018 we collected $42.5 million, we billed $165 million. When you do the gross math, it works out to be about a 26% collection rate. And that's why when we talk about healthcare economics being a little bit jacked up and EMS being part of that healthcare economics, this is what the hospitals deal with. This is what the emergency room physicians deal with. This is what the physician that you see when you have a cold or flu or whatever. We're all in this healthcare space, all dealing with the fact that we rarely, if ever, get paid what we bill, and therefore we are constantly doing this balance of, what's going to be the average patient charge? What can we collect per patient? Can we see more patients at the same cost, so therefore we generate more revenue? Can we do more calls with the same ambulances so that we can generate more revenue to either reduce, eliminate tax subsidy, whatever that case might be? And we're going to get more into the cost drivers for EMS service delivery in subsequent webinars. But Chip, does the Richmond Ambulance Authority payer mix look relatively similar to this?
It looks a lot like this. And we use, the MedStar numbers because they're much more impressive than the Richmond numbers. But last year we billed about $33 million and ended up collecting $14 million. And so, that's, I think, about 43%. And, it is tough. I mean, maybe at some point we'll talk about cost shifting and getting folks who can pay, getting them to pay you. And because, right now it's the haves and the have-nots. And the challenge is working out the numbers so you can pay your folks come payday.
Yep. All right, so a couple of tips as we close this out. We'll open it up for Q&A. If you're in an EMS agency, an ambulance service, just a couple of things to keep in mind. Charge the amount that's related to your cost for service. If you're underpricing the value and the cost that it takes you to provide the service, don't do that because then you're just devaluing the services that you provide. There was just an interesting article in the Houston Chronicle here in Texas that the city of Houston decided to increase the fee for their ambulance transport in the fire department from $1,000 to $1,800 because somebody did an analysis and said, hey, it's costing you, $2,000, $2,200, $2,800 to do an ambulance trip. Why are you billing $1,000? So the city council said, yeah, we probably need to raise our rates to make it more congruent with what it actually costs to provide the service. So just make sure you're doing that. Chip talked several times about making sure that if you're a field provider or if you're a leader and you educate your field providers, really do a good job of patient care documentation because medical necessity is really important because if without it, then the insurance company is going to deny payment, Medicare, Medicaid, third-party insurance. And we talked a little bit about it already, but be careful with network agreements. All these things have a dramatic impact on the revenue stream and on revenue cycle management. So with that, we're going to pause for a moment. Melissa has done a really good job of letting Chip and I know on some backdoor communications here about some of the questions that are coming in. And we're going to start with this one. And then, Melissa, you can just come on the line and tell us if there are others that Chip and others can ask. But one of the questions from one of the attendees is, how will ET3 impact public utility EMS when public utility EMS depends on non-transport, when they depend on non-transport to balance their cost of operations? So if we understand the question properly, remember that when the alternate disposition discussions were occurring with CMMI over the summer last year, they recognized that they need to keep EMS whole in regard to the revenue that they're going to generate for not taking someone to the hospital. So they've said on several occasions that the rate that the ambulance provider is going to get paid for not transporting someone to the hospital is going to be the same as they would have gotten paid if they had transported the patient to the hospital. It's much like Anthem, Blue Cross Blue Shield 2 years ago started to pay for non-transport at about the same rate as they pay for the transport. Because, as Chip said, sometimes those treat and refer fees are lower than the ambulance transport fee, but for commercial insurers, for Medicare and Medicaid, those amounts that they pay are relatively fixed. So in the Medicare world, their fee for the treatment in place will be, in Texas, let's say, about $427, because they generally pay about $427 for the ambulance transport. And they're willing to make that payment regardless of the transport so that they can save the expense of the ER visit that they are going to be billed if we transport that patient to the emergency room. Chip, when you were doing your ET3 analysis, were you sort of doing the same math?
We were, and yeah, something you mentioned, the non-transport to balance the cost of operating. Well, currently we don't get paid if we don't transport. So we just recently looked at our transport percentage, because what we needed to do was figure out if there was some opportunity there. And we started looking at providers to see who was transporting to the hospital and who wasn't transporting to the hospital, for two reasons. One is obviously financial. The other is, they're leaving people at home that need to go to the hospital. We're not doing the treat and release yet. That's an ET3 thing, and so sometimes the folks get a bit ahead of themselves and start doing it a bit early. But no, eventually this whole pay for response, it looks like it could be a very good thing, because I don't get paid at all for response now. So maybe I will then.
Right. So that alternate disposition is going to be really good for us. So Melissa, why don't we bring you onto the line here and see if there are any other questions that you've gotten from the chat box or from the Q&A that you want to throw out to try and stump Chip and Matt.
Good deal. We do have some more questions. One of the questions is, how will disruptive business models such as round trip, acuity link, well ride, ambulance, etc., impact the non-emergent transport and thus public utility models?
Chip, you want to go first?
Sure. So all these, ride sharing, where it's the Ubers or the Lyfts or, currently we're getting paid if it's medically necessary, and that's probably going to be more the trend. And so what we found in looking at these is that they don't necessarily have the same customers that we would. And in some cases, they're taking responses off our hands that we would have gone to, transported, and then not gotten paid for. Now, and still, even if you're paying for response, it's still, ET3 is still tied to medical necessity. There still has to be a reason. You still have to show that, you did something for that patient to fix their condition.
Yeah, excellent explanation. I'm going to throw two things into the mix. First is, much like what Chip mentioned, the rideshare specifically, and the studies have shown 7% reduction in EMS call volume when Uber or Lyft make a significant infusion into the market. And quite frankly, that's okay, because we want those people who are low acuity. And in fact, the American Ambulance Association, NAEMT, others have educated the community. Hey, if it's a low acuity, blisters on your feet, certainly call Lyft. If you're puking, bleeding, chest or pain anywhere mid-brain, call 911, and the rideshare companies do the same. The second part of what the questioner seemed to ask was the ambulance folks like Ambulans and some of these Uber-like ambulance providers operating in an area. When you guys looked at above average EMS budget, or if you look at MedStar's budget, Richmond's budget, we have to provide 911 service, and quite frankly, the 911 service in many communities is a loss leader. Nobody makes money generally on 911 service. because of the payer mix and because of the high impact of the uninsured and Medicaid and Medicare, where you can balance some of the economics is in the pre-scheduled interfacility non-emergency transport. So a lot of system designers, and in every system that AIMHI has membership, part of the high value, high performance EMS system design is you have one provider in the community doing all of the work. It is illegal in Fort Worth, in Richmond, and a number of the other organization communities to do what we refer to as cream skimming, to do the low cost, high paid interfacility transfers. And the reason that the system designers set up the exclusive model was so that the revenue generated from doing the non-emergency work helps cover the cost of providing the emergency work, which then minimizes cost to the patient, maximizes efficiency, minimizes potential cost to a taxpayer. Plus, the medical director knows that no matter what patient is being moved, whether it's a 911 call or an interfacility call, those same EMTs and paramedics that they credentialed to provide that care are providing that care, and they don't have to worry about Jim, Joe, Bob's above average EMS ambulance coming in to transport somebody and maybe having some clinical issues. So I hope that answered the question. Melissa, another question?
Is the GEMT payment available for all states?
Yep. Do you guys have GEMT in Virginia?
We do not. I wish we did. It's a Texas thing.
Yeah, it's available in a lot of states, not all states, obviously, as Chip just mentioned, but it's part of a certified public expenditure issue to a large extent. So in Texas, California, and other these places, they know that the public providers, and generally it's only available for public providers, are generally using locally funded tax dollars because the state is underpaying for the cost of the service. So the state reimburses that government entity for the uncompensated care generated from providing service to Medicaid patients that are paid under the cost of service. So Colorado has it, a number of places do. For those of you on the webinar, check to see if your state has GEMT available, and if you do, take advantage of it because it's a great way to help increase the funding to your system, reduce the reliance on tax subsidies.
Okay.
So you're scrolling through all the questions to pick a good one?
I am. Another question is, or request is for you to expand on the public education piece of selling medical Uber and Lyft type programs. This person feels that due to there would be a public outcry if EMS didn't take people to hospitals. How do you start that conversation?
Yeah, so I'll give you an example here, and maybe Chip, you can kind of give the counterpoint to this. So our nurse triage program at MedStar, we have a specially trained nurse in our communication center every day, and that nurse is given the low acuity 911 calls. And then one of the options that the nurse has available to him or her is the ability to send Lyft to Melissa's house because Melissa called 911 because her son twisted his ankle. And, you know, he doesn't need to go to the ER. He needs to go to an orthopedic clinic or he needs to go to an urgent care. So we send Lyft to Melissa to take her and her son to the clinic. And in many cases, we pay for that because it's cheaper for us to pay that Lyft fee than it is to spend, you know, $400 to send an ambulance to do a transport to the ER that's probably not going to get reimbursed because it's not going to meet medical necessity. So integrating all of those options available brings great value to the payer, to the provider, and to the community. So partner with them. You take the right calls, they take the right calls, everybody's happy. Chip, what's been your experience in Richmond with some interesting programs you're doing?
Well, we had the nurse program, one of the first, if not the first, years ago. And our challenge was, back then, that we didn't have the pathway. So there weren't any good options. And so it's one of those things that's on my to-do list, but we need to put it back back in. But yeah, I mean, the interesting thing is our call volume has been decreasing for like the last 2 years, just a little bit. And so we're trying to understand, is this the result of some of these, entities coming to town? And it doesn't seem to have hurt, financially, because as I said before, these aren't the patients that need us to take them to the hospital necessarily in the first place. And so, yeah, we are all for it, and we don't say, not to use them. Most appropriate care, at the most appropriate time, most appropriate place.
Yep, agreed. With that, Melissa, we've got a catalog of the other questions. Do you or Chip want to talk about what we're going to do with the questions, the audio, and our next webinars?
Sure, I'd be happy to do that. So as per one of the beginning slides when we were teaching you how to ask questions, today we wouldn't be able to get to all the questions due to the volume of participation, which we greatly appreciate. So we will be cataloging and taking in all these questions, and we will have an FAQ section on the respective NAEMT and AIMHI websites so that you can go back to them, and they will be there for all of the EMS finance webinars. Talking about that, the future dates for the next EMS finance webinars will be September 23rd at 1 p.m. Central Time and October 30th at 1 p.m. Central Time. Be on the lookout for that information in your inbox with the topic for discussion and the speakers, the presenters who will be doing that. So really thank you today for coming on board. As well, this webinar was recorded, and we will download it and provide it to the attendees via our respective organizations' websites as well. You will be receiving a email in about an hour. This email will have a link to the evaluation for today's webinar, so please feel free to share with us your thoughts about today's webinar so that we can prepare and you get better every time in future webinars, as well as it will also have all of the information you need to capture your continuing education credit for today's webinar if you would like to do that as well. So again, in about an hour, please look for that. If for some reason you do not receive that by tomorrow morning, please contact myself and let us know. It was in the original, my email address is in the original email that came out to confirm your participation and with information about the webinar. So feel free to reach out to us and let us know so that we can get that information to you.
Awesome. Thank you, Melissa. Chip, any closing comments?
Thanks, everybody, for tuning in, and look forward to presenting some more interesting topics in the future.
Awesome. Thank you all. Have a great afternoon. Bye-bye.